Hello, everyone. It's a pleasure to welcome you to this ICCPR ICRR webinar where we explain the International Cardiac Rehab Registry. We're going to bring some real-world experiences and some insights to you. So the title of this webinar is ICRR in Practice, Tools, Insights, and Real-World Experiences. So first, I would like to welcome our participating ICRR centers. As you can see in this slide, ICRR has been a part of cardiac rehab programs in all WHO regions, and currently we have 22 active sites contributing data to the registry. I also would like to say hi and welcome to our ICCPR community. Currently, ICCPR has 51 cardiac rehab societies as members, and also not listed in this map, we have 30 plus friends. These are cardiac rehab leads in countries where there is no such societies. So welcome everyone to this session. So the objectives of today's webinar are the following. Introduce the International Cardiac Rehab Registry for those that do not know, but it's always good to have a refresh, right? And just share a little bit about this project. Highlight the value of global cardiac rehab data collection, share some practical tools and implementation experiences from participating programs, and discuss opportunities for collaboration, quality improvement, and future engagement. I'm honored to introduce our speakers who will be sharing insights with you today. My name is Gabriela Ghisi. I'm chair of ICCPR and also chair of ICRR Users Subcommittee. I'll be joined by Dr. Carley O'Neill, who is chair of ICRR and also treasurer of ICCPR, followed by Monserrat Cruz, which is our quality improvement lead of ICRR, Dr. Priya Chockalingam, who is a data steward in ICRR and also member of ICCPR or ICRR User Committee, and Ankita Deodhar, who is the incoming secretary for ICRR and also data steward.
Good morning, good afternoon, good evening, everyone. I know we're all spread across different time zones, so thanks very much for joining the webinar this morning, or whatever time it is where you're at. And thank you, Dr. Ghisi, for the introduction. As mentioned, my name is Carley O'Neill. I'm the chair of the registry, treasurer for ICCPR, and an assistant professor at Ankita University in Nova Scotia, Canada. So for my piece this morning, I'm going to share very broadly an introduction of the registry, talk a little bit about the impact, and then my colleagues will share some detailed information in terms of the areas and the features that they lead. So looking at, what is the registry? So very broadly, the Rehabilitation Registry is a global registry where we seek to collect cardiac rehabilitation data. We do so in a standardized way, focusing on improving quality and outcomes. So by doing so in a standardized way, we can look across different programs at different regions and really ensure that the outcomes that we're measuring are consistent across different programs. And it allows us to ensure or to work to improve the quality of care being received in cardiac rehabilitation worldwide. So as mentioned in the introduction slides shared by Dr. Ghisi, you can see that we have a number of participating sites, 22 contributing currently to the registry. So the goal is really to support these programs worldwide. So looking here at the purpose of the registry, there's a few different purposes. So one is assessing and improving the quality of care. So by collecting the standardized data across different programs, we're able to monitor quality indicators. We're also able to identify areas for improvement within your program. And that really works to improve the quality of care that your patients are receiving. So with that, another purpose is to track patient outcomes. So we want to follow patient progress over time in order to understand the outcomes as well as to drive better care for all of our patients. It also allows us to look at regions across countries. We want to share best practices. We want to reduce variation in care. We are a very collaborative group. So the goal of this is to collaborate, to work together to improve the quality of care in cardiac rehab worldwide. And certainly another purpose is to support research and policy. So we're able to provide high quality data to advance research, to help to inform policy and improve cardiovascular health worldwide. When we look at who the registry is for, it's for cardiac rehabilitation programs, like I mentioned. It's also for clinicians and administrators working within cardiac rehabilitation programs. It's for researchers. So going back to one of the purposes of the registry is really to look at that high quality data to drive in evidence-based practice and improve care. And it's also for patients. So at the end of the day, we're all working in a cardiac rehabilitation program in some capacity. Our goal at the end of the day really is to provide the best quality of care that we can with the resources provided for our patients. So when we look at some of the key features and benefits of the registry, we provide an interactive dashboard for you to monitor and input your program specific data. And that's going to allow you to track the performance of your program and your patients over time. It's also going to allow for quality improvement support, and you'll hear from our quality improvement lead later on in this webinar. And this quality improvement support can be used so we can use our feedback and the data insights to identify some of the gaps that may be currently existing in programs and to drive continuous improvement. This allows for real-time feedback within your program, gives you insight into your quality improvement indicators and reports, and overall helps to support evidence-based improvement. Another key feature is data export. So it will allow you to export your program data securely for your own analysis, for your own reporting, and further use. This will help to support and facilitate deeper analysis and evaluation of your specific program. It's also helpful from a patient perspective, so being able to provide patients with easy to understand summaries to help engage patients in their own recovery is really going to provide them with an understanding and a motivation to improve their own self-management. So helping to support that shared decision-making between the clinician or the healthcare provider and the patient. And then certainly research opportunities, as I've mentioned, so being able to contribute to and benefit from a global research platform, advancing the evidence base for cardiac rehab, opportunities for collaborations, and informing policy and improving cardiovascular care worldwide. So we look very broadly about why the registry matters. The goal really is to improve global cardiac rehab quality. So it helps for programs to measure, to learn, and improve to deliver high quality cardiac rehabilitation for all patients. In doing so, we're supporting equity in care. So by identifying those gaps, by driving action, so more people in more places, more regions can access the care that they need. And working to strengthen evidence base. So by generating this high quality real world data that will work to advance research, to guide policy, and improve outcomes. So if you're not already a member and are interested in joining the registry, we are hoping to attract more communities, more programs to the registry. If you navigate to the ICCPR website, you'll see a tab for CR Registry. When you click on that tab, you'll see the photo here that's highlighted on my slide. There's a lot of information that we provide for you. So I really encourage you to take some time, go through the documents that we have available to you, be familiar with the resources that we have. And then if you do want to join, highlighted in the red box on my slide, you'll click the link for click here, and it'll walk you through step by step the process needed to join the registry. So a couple key things we'll ask is to confirm eligibility as a cardiac rehab program. You'll complete a registry interest survey. You'll obtain required approvals, sign registry participation agreements, and then we do provide onboarding and training sessions, which we'll talk about next. And then from there, begin entering anonymized patient data. So with that being said, it sounds easy, right? Just click on the link and the rest will come. But we also provide ongoing support. So like I said at the beginning of this, we are a really collaborative group. We're all here to work together to improve cardiac rehab programs worldwide. And in doing so, we will provide you with support as you need it, whether it's joining or whether you've been part of the registry for a while, we are here to help. So we offer live training and onboarding support. We provide templates if needed. There's technical assistance available with the registry platform. There's performance dashboards and reporting tools. We have leads in a number of areas that you'll hear from next. So we have guidance with quality improvement, and global collaboration and learning network and ongoing support from our registry team, all available at no cost to your program. So with that, I'm now going to hand it over to Monserrat. So Gabriela, if you want to share your screen, I'll go ahead and stop, and then you'll hear from our quality improvement lead.
Thank you very much. Good morning for some of you guys. Thank you for having me in this webinar. My name is Monserrat Cruz, and as I mentioned before, I'm Quality Improvement Lead for the ICRR Users Subcommittee. And next slide, please. As previous mentioned, I'm gonna talk about how the quality of our programs can be improved through the ICRR. And first, we will begin with a brief introduction to provide some context, and afterwards, we will discuss the quality standards in cardiac rehabilitation. As Dr. O'Neill mentioned before, it's important for us to be in the same page, to try to have the same standards. And then we will address the main question of this presentation on how does participating in the International Cardiac Rehabilitation Registry help to improve the quality of our programs. And finally, we will conclude by sharing some useful resources for quality improvement. Next slide. So what is quality of care? The degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. We'll see that one of the main outcomes in cardiac rehabilitation programs is for the patients to achieve certain level of education on a healthy cardiovascular style of life. So if we don't place certain standards, that's a topic that is pretty difficult to measure, like the degree of the education of the patient on those matters. So we need to standardize certain indicators of quality. Next slide, please. So care quality is a multidimensional construct that incorporates the concepts of safety, equity, evidence-based medicine, timelines of care, efficiency, and patient-centeredness, which is my favorite one because all around the world, the patients have different goals, different needs, and also different resources to achieve this cardiovascular healthy lifestyle. So it's important for the patient to be in the spotlight of the attention of the whole team. Next, please. So to quantify the quality of cardiac rehabilitation care, evidence-based recommendations need to be translated into well-defined, evidence-based, and measurable elements of practice performance. These elements are known as quality indicators. For the case of the ICRR, we'll call them quality standards. And as you can see in these slides, different associations all around the world of experts have provided us through decades with these standards of quality care in cardiac rehabilitation. Most of them are about the same, and I really love these images on the papers because I think they are pretty clear and I just love to see them. Next slide, please. So the ICRR cardiac rehabilitation quality standards were selected based on the ICCPR consensus statement on cardiac rehabilitation delivering low resources, a review of cardiac rehabilitation quality indicators that we just reviewed in the last slide, clinical practice guidelines, the WHO package of rehabilitation intervention for ischemic heart disease, the European Association of Preventive Cardiovascular Care Standards and Quality Indicators, and they were also informed by the ICRR Delphi process when the ICRR were being developed for variable selection and subsequent quality indicators. So I think this is a pretty good review on how the ICRR quality standards for cardiac rehabilitation are not just based in a certain area or by certain group of experts in country or in certain resources. They are they were collected by all around the world literature, so they pretty much cover different settings all around the world. Next slide. So I created this flyer, I'll say, on the cardiac rehabilitation quality standards to give a pretty good overview of them. We have 13 that are measured in the ICRR, and the first of them is a comprehensive program that will try to assess different variables on the patient, not just the exercise tolerance or the cardiovascular healthy diet, but a lot of the items. It has to be delivered by a multidisciplinary team. Also, it has to have in place the cardiac emergency politics for each region and country, and for different settings. If the program is inside a hospital or is in a clinic, or maybe we are talking about telerehabilitation, every program has to have the emergency policies in place. The fourth of them is assessment of tobacco use. Number 5, assessment of blood pressure. And also we are going to measure the program completion rate. The rate should be less of 50% of the participants in the programs need to not drop the program by other cause, that is mortality rates. So we have to achieve this level, and also for more of 75% of completers, they have to achieve at least 0.5 meds post program. And also the mean post program quality of life had to increase, and also the participants have to achieve more of 150 minutes of physical activity per week. They have to report that they know what are for their medication, and also how to take the blood, the heart pills, more of 70%. 70% of the participants have to know how to keep control of their lipid profile. Also, more of 70% have to know how to take care of their diet, and also more than 70% had to report that they are again keeping the roles in the ones that are important for them, because they can be different for each one in their life, and we have to help for that. So as you can see in this flyer, and thinking about it, most of the programs all around the world already cover all these areas, but they don't know. Why they don't know? Because they don't measure. And that's why it's important to have to be part of the ICRR, because that will help us to take a look and to see what's going on in our program and try to improve. Next slide, please. So to sum up, there are 13 program reported variables and 16 patient reported for the ICRR. Some of them we report through our assessments, and some others the patient will self-report. And these variables include patient socio-demographic characteristics, clinical characteristics, treatment received, outcomes, quality of life, cardiac symptoms, and morbidity and mortality. Next slide. So how can we help? Once you are in your program is under the way of in the ICRR, as Dr. Neil just mentioned, you can always reach out. That's why that's what we are for. My email is in this slide. We can always review how are you doing on your standards by going through the data that you upload to the registry. Also, you can go for the ICCPR certification as a provider. We always have updated material that can help you to improve your practices. We are meant to give 2 quality improvement sessions each year. You can always attend. They are free and they are always I think they are pretty valuable because it's about not just the speaker talking, but sharing experiences. And you can always send an email through the ICCPR official Gmail account to share how you're doing, what's going on in your program, so we can talk about it. And keep checking your email for QI communications. I just want to highlight, as the previous QI chair, Dr. Abraham Babu, we are non-judgmental. No program can be high quality in all areas. So this is not about to score 100% of everything. I think the beauty of it is that there's always room to improve. And we can always pick one area to start. We can't cover all of the same time. So this will be more feasible to improve, to have an approach to improvement. And I think that's pretty much it. Thank you very much. Oh, I sorry, as I just said, most of the programs all over the world are already achieving these cardiac rehabilitation quality standards. So they just don't know. Next, please. So we need to measure if we want to improve. Thanks for your attention.
I'm just going to say hello rather than good morning, evening. So, hello everyone. I am Ankita Deodhar, a cardiovascular and a pulmonary physiotherapist. I have previously worked with Sir H.N. Reliance Hospital in Mumbai, India. I have been a part of the registry through the Indian site where I was involved in implementing a day-to-day use of the registry into a cardiac rehabilitation. Currently, I am a trainee secretary for ICRR, and today I'll be sharing certain experiences with the registry. So, why we joined? Why was the need? So, at our center, we already had a well-established cardiac rehabilitation program, and we were already collecting patient data internally. However, the limitation was that we were collecting our own center data and without any broader information or benchmark standards according to the international standards. So, joining ICRR provided us a structured framework to systematically collect and evaluate data within the global context. It allowed us to compare our outcomes with the international standards to understand whether a program or whatever exercise planning that we are doing is improving our patient's outcome or where were the lacunae. So over the time, this helps us to achieve a stronger data clinical outcomes and meaningful improvements. So that's why we could standardize our data to the international standards and were able to achieve the MCID values in a better way. Importantly, it also gave us an opportunity to represent Indian data onto a global context, which is usually underrepresented into literature and registries. So how we eventually use the registry. We integrated the registry into our routine workflow by collecting the baseline data at the program entry and follow-up data towards the discharge. We had a 4-week exercise program sessions. So we tracked a certain quality indicators, which were exercise capacities, cardiovascular risk factors, adherence, and other patient outcomes. So the registry also helped us to better understand the appropriate patient inclusion, gradual titration of the exercise programs, and develop standardized protocols within the program. At the same time, it helped us to individualize exercise program. For example, like we have a younger population undergoing cardiac rehabilitation or enrolling into cardiac rehabilitation, requiring more return to work activities, or sometimes progression of the exercises for them is fast, like a faster as compared to when you have to compare it for an older population, which requires a gradual exercise progression, or sometimes balance training, functional training activities, or basically for day-to-day activity improvement. So the registry helps us standardize these approaches, but will also helped us to provide an individualized exercise program. So how did we improve our program through the accessibility? So initially, as coming from an Indian site, before implementing, we figured out that regional language and communication were important barriers that were maybe becoming an hindrance for the patients to be included or participation into the exercise programs. Sometimes, especially the elderly population or a non-English speaking population. So we also noticed certain cultural or language barriers played a very important role for us to shape our exercise program and to improve the adherence into the program. Also certain barriers that we noticed were gender bias differences. We also figured the women were less likely to express their problems or the issues they are facing, or their participation was lesser as compared to the male counterpart. So after introducing these changes, we saw there were clear understanding between the patients, what they are undergoing, what their goals are going to be. So the interaction between the therapist to the patient improved. So this gave us a better understanding. The patient understood what they are going to go for the next 4 weeks, what they are going to be doing through the next 4 weeks, rather than just simply coming, doing some exercise, and then going off. So communication became a very important factor that helped us shape our exercise program, which eventually helps us to improve the adherence and participation into the program and better outcomes. So how did it impact our clinical practice? So the registry had a significant impact on our clinical practice. It is not only consistency of documentation, but we could incorporate the documentation in an everyday utilization, so that we could use it for follow-ups, we could use it for patient outcomes. For example, we were able to recognize that the nutritional assessment, which is an often overlooked or sometimes just missed aspect of our exercise program. So we incorporated certain changes, like including informal food recalls, or talking to patients while they are doing exercises to improve, so that we could understand the real time eating patterns. Also we included some behavioral counseling sessions into it, so that we could understand whether certain habits are emotional eating patterns or the other lifestyle related issues, which were addictions, and could provide a timely guidance to them. So overall, the registry shifted our attitude from more patient driven approach, enabling us more informed, structured, and patient centered improvement into the delivery. Of course, we did face certain barriers while integrating it into our program. From the So that's why from the registry, they implemented the major key lessons that we learned, that we could integrate. The program was so simple that we could integrate it into our daily workflow, not treating it as an additional documentation task. So we could engage our team stronger. We started small, started putting smaller goals, and eventually, attended all those multidisciplinary approaches to strengthen the quality of the data. The key barriers at certain times that we identified was, of course, documentation, coming up with implementing processes. So cultural norms, also communication, of course, but eventually we improved, and so that we could get better outcomes. So why does all this matter? Why are we doing all of this? The local data that comes from a smaller or a lower healthcare sectors gives us a better insight for placing it into the global context. It reflects the real world diversity of the population, which is often underrepresented. This makes the evidence more relevant and applicable for daily clinical practices. It also strengthens the advocacy to provide concrete population specific evidence to support system level changes and resource allocation. Most importantly, it drives inclusivity by ensuring diverse patient voices and experiences that are captured, ultimately leading to more equitable and patient centered care. So, towards the end, I would like to say that this work highlights the importance of moving from data collection to meaningful change. Data, when used effectively, is not just about recording. Information becomes a powerful tool for transformation of the clinical practice. It enables us that better patient care by identifying gaps, guiding improvements, support informed decisions, and at the same time, it strengthens collaboration between the teams and based on evidence. Ultimately, data should not remain static. Actively applied, it drives continuous improvement, better patient care, and meaningful patient outcomes. In the end, I would just like to say thank you for listening to me. And of course, the experience with the registry was very beautiful. And right now, also, I'm continuing my journey with them. So thank you.
Dr. Priya Chockalingam. I'm the clinical director of Cardiac Wellness Institute in the southern part of India. It's a coastal town called Chennai in India. So we started Cardiac Wellness Institute about 12 years ago now, 2014, and it was and still continues to be an exclusive, or I would say one of the first exclusive outpatient preventive cardiology centers in the country. We offer cardiac rehabilitation, pulmonary rehabilitation, and cardiovascular disease prevention programs. We're proud to have a multidisciplinary team right from the beginning with well-qualified professionals. We are currently providing center-based, home-based, as well as hybrid programs, especially after the COVID pandemic. We have gone more online and home-based. And so we have a lot of publications from our part of the world. Ankita, I'm not sure, I just joined a little bit late, but just to give you a perspective, India is still just catching up on the cardiac rehabilitation wave. So we are glad to be referred patients and people's and cardiologists and professionals trust as well. So I'm really glad that our story and the collaboration with ICCPR, next slide please, yeah. So we have had an ongoing collaboration again for quite several years now. I think it initially started with the original research paper with which Dr. Babu and Sherry and the team of ICCPR published, showing that the results of cardiac rehabilitation in India were quite comprehensive. I mean, the quality was good, but still there were some areas that needed upskilling and upgrading. So then we conducted our own multi-center research on the cardiac rehabilitation programs in India, and we were happy to see that almost all the areas were served well, the different components, but still data capturing and needed improvement. There were some structural variations between all the centers in India. I mean, when I say all the centers, there were a handful of centers. So we were actually lot more to be done in this area. So from 2020, we've had good communication with the leadership team of ICCPR, and we started using the registry from the end of 2021, beginning of 2022. I have been serving in the ICRR committee as well. And now we have myself and my physiotherapist who have been certified by the CRFC, which is an excellent initiative by the ICCPR. We are very happy to have this certification as well. Yeah, next slide, please. So just to give a snapshot of how the registry works, so we get referred patients. We are an outpatient rehabilitation center. We are not part of any bigger hospital, so we are a standalone community-based, and we get referrals from healthcare professionals, cardiologists, cardiothoracic surgeons. Sometimes it's self-referral by patients themselves. So we perform a baseline assessment, and all of the information, relevant information from this assessment gets uploaded in the pre-program entry in the registry. And then the patients go through their rehab sessions, and then we have a post-program assessment as well. And the assessments are quite comprehensive, including functional capacity, nutritional assessment, and psychosocial assessment, and all of that. So we use our own internally developed questionnaire in addition to the verbal questioning, history taking, etc. So this questionnaire that we use also started incorporating the questions that the registry was using. So it did, there was some initial hiccups, but it became streamlined very soon. So now patients just fill one single questionnaire, and then we are able to use the relevant responses and enter them into the registry. And then there is this annual maintenance or follow-up part of the registry, which some of our patients re-enroll and they join a maintenance phase, but not all of them do. So that part is something where we're still working on and trying to see how we can improve the uptake. So our physiotherapists are registry trained by the ICCPR, especially when the particular person who's going to be handling the registry, so they get trained by ICCPR. That's very useful. And then, as I said, our intake questionnaire has incorporated the ICRR questions. Manual data entry is done in the registry. We try to do it on a weekly basis. Yeah, so that's something that we try to do as an weekly rota. So, and then data is updated after a minimum of 12 sessions. So our patients enroll for a minimum of 12 sessions, and we encourage them to go on to 24 sessions. So we call a 24 session program an intensive phase of the cardiac rehab program, but not all of them would enroll for 24 sessions right up front. So they might be willing to first start with 12, enroll for 12, commit for 12 sessions, and then several of them, I would say, go on to do at least 24 sessions. So we have as 12 sessions as the minimal requirement. And then annual follow-up data is recorded based on whether they're on follow-up, whether they're able to fill the questionnaire after a year, and so on and so forth. Yeah, next slide, please. So we are really happy that the registry has, nourished us in several ways. So it serves more than just a database. It definitely has helped us to benchmark ourselves with other centers, globally. So it helps us track our outcomes. It supports the monitoring of risk factors, because we are able to systematically monitor how the risk factors progress during the program and even after the program. It assists in assessing patient adherence. So this is something that is very useful, because when we look back and we look at our, let's say, last year's patients, so we are able to say see very clearly how their adherence has been. Follow-up tracking is enabled, and also it enhances patient awareness. So when when we discuss and counsel them on their, how they have performed at the start and at the end of the program, so that also increases their motivation to, let's say, proceed on with another phase and with the maintenance phase and to be on a longer term follow-up, etc. Yeah, next slide, please. So this is a screenshot from the registry itself. So here it's showing the changes in the physical activity of our patients. So this is our patients' outcomes report. So it gives a compilation of our patients. So when you look at the top part, it says MBPA, change in MBPA. So moderate to vigorous physical activity is being tracked, right? So from pre to post, there's been a change of significant change of about 20 minutes per week. And then you go on to quality of life, you do see that again there is a significant change, and in the number of portions of fruits and vegetables that they intake. So all these are crucial and significant changes, and when we look at it as composite data like this, it is very clear as to how we are progressing with our patients. Next slide, please. And yeah, again, a little further, we go on to see how many, these are some questions which the registry has incorporated in it. So how many of our patients know what to do if they have chest pain, right? So because they have had a coronary artery disease, and they have, most of them, come with a coronary artery disease history, but it's not necessary that they know that they've had angina. Some of them might not be that aware that a second heart attack is even possible. So these are some things which we educate them on during the education session. So ours, again, is, as I said, our programs have exercise, diet, as well as education and counseling as part of their sessions. So this aspect we have started ensuring that we talk to them about this, about a possibility of a second heart attack. Again, we don't want to frighten them, but we at least need to let them know that we are seeing quite a few patients with multiple coronary artery events, and so we need to keep them aware that what needs to be done if an event happens. Again, the cholesterol level. So this is something that quite a few of them, because they come referred from outside, let's say another hospital or another clinic. So not all of them come with their, lipid levels. So, but then now we are trying to encourage them to at least, get one pre-program lipid level, and also try to follow it up with a post-program level when they complete the program. Next slide, please. Yeah, so impact of the registry, it has definitely impacted our clinical work, our team dynamics, and it has impacted our academic outputs as well. So in the clinical work, this structured assessment is happening because now we are part of the registry and we cannot do it haphazardly anymore. There's thorough documentation, there's improved patient engagement, there's systematic follow-up, and if patients are showing signs of dropping out, then we really have to make sure that we communicate more frequently, try to understand what is happening at the patient's end, and try to help them overcome that barrier and probably get back on track with the sessions, for instance. And it has definitely helped us improve the outcomes with our patients. And then the team dynamics, of course, now the team is more accountable, so all of them are working a bit more conscientiously, and that definitely there's better interdisciplinary coordination. It has always been there from the beginning, but now that we know that each of the component actually contributes to the final outcome, and it is all in you look at the patient outcomes, you can look at it very clearly. So each of them is eager to deliver better, and they're also now eager for research collaboration. So it's very heartwarming to see. So recently we were at the European Society of Cardiology's preventive conference in Slovenia, and myself and my physiotherapist Agalia we both had clinical cases and abstracts presented there, and it was wonderful to see. You know, just networking with global peers is an excellent feeling, but it was wonderful to see how, again, without, I think, the registry support, all of this would have been a bit more challenging for us. And the academic outputs, so our presentations and publications in international forums, a data-driven approach to the entire cardiac rehab and prevention programs, and then participation in the ICRR's quality improvement project. So that's something which has been very useful. So and again, they have had interesting topics, especially topics that are not covered in normal forums, like psychosocial aspects, nutrition, sexual well-being, etc. So I think all of these are wonderful initiatives of the organization, and we are very happy that the next thing that how the registry has helped us is in the benchmarking, right? So now what you see here is how we have performed in comparison to the rest of the sites, so globally. So I'm very glad to see that we are doing well. So it's a wonderful feeling when you are able to compare yourself with so many other people who are working in a similar space. And again, the next slide, we would also be able to see where some areas, which are the areas where some sites are finding it challenging. Like, for instance, an all sites completeness, you see that some of them are marked as orange. That means those are the areas like which, for instance, psychosocial well-being and feelings of depression, etc. Not all of them are filling it out, but we are faring a little bit better. Again, these are not like above 90% even in our case, but we are faring slightly better. So I think these are some I just thought we should share some of the actual data that is there on the dashboard, and it really helps us on a day-to-day clinical care basis. Next slide. And as Ankita also pointed out, there are always challenges and barriers, and one of the most important things for us is follow-up data. So we still miss follow-up data. So if you see our annual follow-ups, it's a lot of it is in red. That's because, as I was alluding to earlier, a small proportion of our patients only re-enroll or continue with annual follow-ups. And when they don't continue, they are kind of lost to follow-up. So we try communicating with them, contacting them through emails or phone calls or WhatsApp, but very few of them do fill up repeat questionnaires when they're not actively on the program. So that's a major challenge. And of course, a few things like missing LDL values, missing ejection fraction values in the post-program evaluation. So these are some things which we are now trying to work a bit closely with the referring cardiologists as well to make sure that we have some completeness. Yes, again, next. And on the I think overview, the bigger major setbacks or issues that we have had are low volume of referrals, mainly because of the lack of awareness about cardiac rehabilitation. That still is a huge gap that we have been trying to conduct continuing medical education programs, one day or 2 day meetings, conferences. And I mean, it's interesting to see that at that time there's a lot of interest and people do sign up and register, but then later on they go back to their original way of just managing their patients. So cardiac rehab is still not incorporated in the regular care of cardiac patients, and we have some more to go before that happens. There's lack of insurance cover. That's a big drawback. I think Maharashtra has some insurance coverage, but of all the 30 states in India, that's the only state that has managed that. So I think we still have work to do there, and we also need to improve our adherence. We are quite good. The adherence rate is at least about 70 to 80%, which is excellent, I would say. But if we can improve that better, that would also be useful. Yeah, next slide, please. Yeah, and just before I close, so I think the most important things to note are there's a top-notch leadership team at the ICCPR and the ICRR level. The registry benefits the participating in various ways. It's a win-win situation. There's no doubt about it for both the registry and for the participating centers. And the global reach, the networking, and the research collaborations, these are amazing supporting things to have. The professional development and the upskilling support that they offer is also, very, very useful. And I think a supportive net and expert guidance. I mean, it's just an email away, and it's very nice that the close collaboration. They keep the close connect all the time. So there's not 1 week that I don't get an email from Gabriela or the ICCRR or the ICCPR. And I think overall our experience has been amazing, and I would be more than happy to take questions. And in short, everybody who's running a cardiac rehab in this part of the world or in developing countries, low resource settings, should be part of the registry. And thank you very much for your patient listening.